Hello, everybody. My name is Azra Baab, and I am the Associate Director for ASDO Admissions. I have been with the school for 12 years, and I lead the recruitment for ASDO Admissions. Just a little bit about me. I am a first generation college graduate. I actually went to university in Australia at the University of Wollongong. And then I moved here to Arizona in 2008, and I've been here ever since and absolutely have been loving the work that I do at ASDO. But enough about me. I'm actually going to talk about recruiting scholars for community-based dental education. All right, so I'm going to go over ASDO's admissions process, ASDO's interview process, how we select a class, our hometown applicant strategy, our hometown applicant success, as well as our graduation survey and where our graduates are at. So I absolutely love this quote from Dr. Jack Dillenberg. A good clinician or dentist cannot solely care about teeth. It's about a person attached to the tooth, the family attached to the person, and the community attached to the family. At ASDO, we want students to be leaders in their communities. And down the road, we teach them to be great clinicians. We wanted to find new ways of assessing a candidate's personality, their presence, and motivation for pursuing not just dentistry, but serving the underserved. We wanted to find additional ways to ensure we were selecting applicants that truly met our mission, that would lead to positive changes in the communities that they would serve. And in order to do this, we need to look at our admissions process. So applicants applying to ASDO must possess the following. They have to have a completed ADSES application or Associated American Dental School application. They have to have a completed secondary application as well as dental aptitude test scores. Once an applicant gets above our minimum once our applicants get above our minimum GPA requirement, which is 2.75, the main criteria we do consider are community service and volunteerism. The students who come to our school have an average of 700 hours of community service and volunteerism. And applicants' commitment to volunteerism, in addition to the host of other responsibilities an average aspiring dentist has, is what makes a great candidate for ASDO. We also pay close attention to an applicant's socioeconomic status, and that takes and we take that into consideration when we are reviewing an application. We also encourage all of our applicants applying to ASDO to also submit a letter of recommendation from a community service supervisor that they have worked with in order to truly gauge their passion for service to their communities. So the next slide, I'm going to show you exactly how we look at an applicant and why we take holistic admissions very seriously at ASDO. So in this pie chart right here, at ASDO, we monitor and reassess each criteria on an ongoing basis. Each section that you see here is weighted and an emphasis on community service, dental experience, extracurricular activities, and socioeconomic background and other attributes are what make for our diverse student body. All right, so we're going to go into our interview process. So our interview evaluation also contributes to our selection of our diverse student body. We do not want to miss out on a great applicant just because they may not show up well on paper. Our interview process consists of a panel interview, multi-mini interviews, and Kira Talent. The panel interview is composed of ASDO faculty, alumni, staff, and dentists from our local community. The multi-mini interviews at ASDO are slightly different to traditional MMIs. We incorporate standardized patients into our interview process, and each applicant rotates through 3 different stations. The MMIs for us measure competency, empathy, compassion, social, and nonverbal skills. Finally, we also incorporate Kira Talent into our interview process. We needed a structured way to provide our admissions committee with an in-depth insight so that the candidates we were interviewing were able to, we could transform the admissions process by combining on-demand, timed video, timed written responses, and also overall just a more holistic approach to viewing our applicants. This in turn has helped us find some diamonds in the rough that we would have otherwise overlooked with just a traditional interview setting. Tweaking our admissions process has helped us find new ways of evaluating candidates. This ensures that each class we bring in has shapes and advances ASDO's mission and aligns with our school's vision. I love this quote by J.P. Metchek, Associate Dean for Student Experience and Services at Questrom School of Business. There's so much more to every candidate than a test score or an essay, or even the interview process. And the reason I love that is because you can produce great clinicians. If we start helping students that want to make a difference and combine them with nurturing faculty members that grow and encourage that passion, then we can truly make an impact and improve the health disparities in our communities. I'm going to talk a little bit about our hometown applicant strategy. So hometown applicants at ASDO help meet the needs of community health centers by identifying, attracting, and educating dedicated, motivated, and qualified community-minded healers. A hometown endorsement from a community health center lets ASDO know that the applicant has the heart to become a compassionate, community-minded healer. Hometown applicants that meet basic academic requirements are automatically granted an interview. As you can see here from this table, there are some years where ASDO has received more hometown endorsements than others. But our success with graduating hometown scholars still remains high. So on average, ASDO receives anywhere from 2,800 to 2,900 applications per admission cycle. We interview only 13% of those applicants and accept 4%. Out of the 4%, only 3% matriculate. Now, if you look at the hometown applicants, we interview 74% of them. 31% are accepted, and 29% of them matriculate. So look at our graduate survey. Of the 923 graduates of ASDO, 40% have gone straight into specialty or residency training, and 58% have gone directly into practice. Out of the 923 graduates, 179 have chosen community or public health. Over a third of our graduates who graduate from dental school who do not go into specialty or residency training or private practice go into community public health. Nationally, only 5% go into community or public health. All right, thank you. I'll turn it over now to Dr. Wilson.
I come from people who don't usually need a microphone, but I'm gonna be cooperative and use the microphone. Okay, great. And does this have a pointer function too, or no? Okay, we're gonna find out. All right. Hello, I'm Maggie Wilson. I happen to be the Vice Dean of the East Carolina University School of Dental Medicine. We're located in Greenville, North Carolina. Some of you may have heard of Greenville, South Carolina. Make sure you get on the right airplane. And Dr. Wanda Wright is seated here in the burgundy, is our Assistant Dean for Diversity, Equity, and Inclusion. And we just appreciate all of the organizers inviting us to be here today. Love the title of Admissions Revolution. And so we're going to get bold here for a couple of minutes. And specifically, we wanted to focus on our school's experience related to community-based dental education or community-based education and how that helps us to achieve our mission. And this is just one school's perspective. A little bit about us. This particular magazine article came out in the fall of 2011. We are a new school. We have graduated 7 classes now. Dental school is 4 years after college. And in 2011, the fall, when the inaugural class matriculated, this article came out. And the reason that our school was established was because there weren't enough dentists in North Carolina taking care of rural, underrepresented, and disadvantaged backgrounds. And so the idea was to have a model that was going to specifically take care of those particular folks. So our model is specifically related to North Carolina. We only take North Carolina residents into our class. We all know that geography matters and it makes a difference worldwide. And that's certainly the case for us in Greenville. Now let me see if there is a pointer. Doesn't really work. Okay. All right. So this is Greenville, North Carolina. That's Virginia. That's South. You figured out. Y'all know geography. Okay. South Carolina is below us. So we are in Greenville, and you'll notice that there are a number of major highways that go through there. And also, North Carolina has been was a state where there was a lot of tobacco farming that occurred. I think we're also the sweet potato capital of the United States, maybe. If you're from a state that does sweet potatoes, and I've misstated that, my apologies. But we know that the social determinants of health are so important with respect to oral health and general health. We're a very rapidly growing state, and the demographics are really changing. We're increasingly diverse. There's a lot less emphasis on growing tobacco these days, thankfully. That's a good thing. A lot of manufacturing is going offshore as well. And so all of that has had an impact on how our communities have responded. We also know, not surprisingly, we've heard this theme in other places, that our healthcare professionals are in some cases unevenly distributed. They may be more in the urban areas and not so much in rural areas, and that's definitely the case with regard to the dentists. And it's those community needs that led to the decision that we needed a dental school at East Carolina University. Many of you, I'm sure, have heard this quote from Stephen Covey's 7 Habits of Highly Effective People. And we really approached, and actually I wasn't part of the we at that point that established the vision for this school, but we really wanted to establish a school that envisioned that we were going to be taking the healthcare and the educational process to the communities that needed it the most, because we want to educate the students in the very communities where we want them to practice. I'm so sorry. Okay. And so here are our bold vision and mission statements. And so as our Dean Greg Chadwick says, we want to educate leaders who happen to be dentists also, who are committed to caring for underserved populations and improve the health within North Carolina and the nation. So it's those needs of the people of North Carolina that drive our mission. And then our mission is what determines everything else, whom we hire, whom we admit, what our educational and clinical programs are like. Many people think this is the dental school, and this is our beautiful building located in Greenville, North Carolina, but this is not really the whole story. This is the East Carolina University School of Dental Medicine. We have a hospital residency at our co-located Vidant Medical Center. And then we also have 8 community service learning centers. Think of them as branch offices of the School of Dental Medicine located across the state. We're the only dental school currently in the United States that has this model. And we are very indebted to the people of North Carolina who allocated the resources in order for us to be able to do this. And this next map will show you a little bit more about where they're located. So from Silva, the western outpost, which is all the way over in the left-hand part of the state, to Greenville, is about 5.5 hours. And so we are covering a lot of real estate, a lot of geography. And we all know that the more time people spend caring for people of need, then they're going to be more likely to practice in that way as well. And so we really focus on our students spending time in their 4th year, more than half of their senior year, in those community service learning centers. So they see patients in Ross Hall on the main campus during their 2nd year, their 3rd year, and about 40% of their 4th year, but then 60% of their 4th year is out in the communities of need, in the communities where we aspire for them to practice. And they are working and living and in the grocery stores, encountering people within the community who have those needs. And these are all set up the same equipment, instruments, supplies, electronic health record, and it's more of a group practice type setting. And you can imagine if you are the mayor of one of these small communities and you have ECU School of Dental Medicine in your community, you're pretty excited about that. Dr. Wright, you're in my slide. Yes, you've seen that picture before, I know. We leverage the community service learning centers in a number of ways, and Dr. Wright and colleague Dr. Mark Moss received a grant from the Duke Endowment to develop a a school-based program to reach out to children in Bertie County, which is right next to the county where one of our learning centers is located, where there's a tremendous amount of need. And they're able to provide care for the kids, and they set up mobile clinics or mobile dental equipment at the sites. And how long are you typically at like one of the elementary schools?
It depends on the number of consent forms.
So like 2 months? Could be 2 months, and then they go to the next school and the next school and the next school. And so the dental hygienist can do the cleanings and the fluoride and the sealants and the imaging, and the dentist does the exams. And then if the patients need additional treatment, then they can go to our closest, which is still 30 minutes away, Community Service Learning Center for treatment. And just received a grant, congratulations, for Jones County, to do another one of these programs. So it's sort of like a hub and spoke kind of approach. We also want to get the right people on the bus, sitting in the right seats. So for us specifically, let's talk about it from an admissions perspective. We want to make sure that we have people who line up with the mission of our school. Our admissions process is not about who's got the highest GPA, right, Azra? It's about who is going to best fulfill the mission of our school. And notice that it very clearly states rural, underrepresented, and disadvantaged. That is what we want to do. People who want to practice and take care care of people in North Carolina who haven't had access to care previously. We all know that recruitment and admissions are very relationship-driven activities. It's not just processing paperwork. There's a lot of talking with people and developing relationships. We're very blessed. Dr. Wright is the PI on, I guess we're in our 6th year of the HRSA scholarships for disadvantaged students. We get $640,000 from HRSA per year, and have been able to, we can offer up to $20,000 scholarships per year for students who meet that level, who meet that definition. We're very involved with the advisors because most North Carolinians stay in North Carolina to go to undergrad. Reaching out with the high schools, try to be very high impact, high touch, and we'll say a little bit about our Preparing Tomorrow's Dentist program. It's 2.5 days. It was originally funded through the American Dental Education Association with some Robert Wood Johnson funds, and we received a grant of $12,000 to do something in 2.5 days. So brought together some faculty, and we're like, okay, what are we going to do? And so it's very high touch, high engagement for those college students, and with an emphasis on people who align with our mission, who are from North Carolina. And to date, we have had nearly 500 students go through that program, and 77 of them have matriculated into, and some have already graduated, obviously from our dental school. And the estimated cost is $71,000 for all the years that we've done it. We've been self-funded, and we're going to continue. We've received some additional funding from another philanthropy entity this year. And those community service learning centers, we're able to reach out. They are located in the communities of need, so we're about workforce development in those areas. And so we have some of our dental students and our team members actually reaching out to the high school students and some of the early college students to help them to see dentistry as a career. Our dental class size is 52. All North Carolina residents from a number of different counties, a number of rural counties, because we view rurality as a dimension of diversity. And we have a number of students who are financially disadvantaged and people who are first generation college. Few more women than men these days in dental school, and we have fairly good diversity as well among our students. And I think we've all seen slides similar to this that show that the population demographics of the United States are not necessarily reflected in the oral health in the healthcare workforce, and that certainly is the case within dentistry as well. And we know that diversity matters. Again, I feel like Dr. Caper said earlier, preaching to the choir here, that it's very, very important for individuals in the communities who've not been seeking care to be able to be cared for by people who are racially and ethnically concordant. We also know that students who are from rural areas are more likely to go back and practice in rural areas. Oh my goodness. So let's talk now about what are some of our outcomes and what are the promises that we made to the people of North Carolina when we said that we were going to establish this school and achieve these objectives. We have 100 counties in our state, and we currently have students or alumni from 86 of those counties, hoping to add to that. And many of our graduates, and we'll show that in just a minute, practice across a number of different counties as well. Talk a little bit about diversity. This blue line, the horizontal line, shows the percent of individuals in North Carolina who are from the historically underrepresented races and ethnicities, so Black, African American, Hispanic, Latino, and Native populations. The purple line, which goes up and down a little bit, are the demographics of our entering class at East Carolina University. That green line shows that nationally, dental students are in 2001 new dental students were 18%, and we were very fortunate to be at 39%. The dentists in North Carolina are only 13% from those underrepresented groups. Our patient care activities stretch all the way across the state, and many of these people these people. Many of these folks would not have received access to care if it weren't for our School of Dental Medicine, and 30% of them are patients with dental Medicaid. Technology allows all of us now to leverage our healthcare. Wish I could tell you more about this slide. I'll be glad to after the fact if you'd like. We keep the debt load low. We're going to talk about why and how. Why is because we know that has an impact on where people practice. Dental education is very, very expensive. Dental and veterinary medicine are the two most expensive because we basically run our own hospitals. We are so pleased that our graduates in 21 had debt of $115,000 compared with an average of about $300,000. In some of the private schools, it's much more. It's much more than that. And how do we do it? We live in a state that helps us to keep our tuition and fees low. We're a very lean organization, administratively as well. Dr. Wright and I wear multiple hats, just as many of you all do as well. We are really aggressive in pursuing loans. North Carolina has forgivable loans for service as well, and we're able to use some institutional funds for need-based financial aid. And as this slide shows, we're the 7th lowest tuition and fees in the U.S. And so that's a huge part of our model. 90% of our graduates practice in the state of North Carolina. This slide shows the percent who are currently in residency, but 90% are practicing in North Carolina, and of those, actually 87% are practicing primary care dentistry. And we practice now in 65 counties. Want to color in that map totally purple one day. And, oops. I do work with my hands for a living, so I apologize for that. And right now, 59 of the counties that our graduates are practicing in include dental HIPSAs. Now, there are a lot of questions about, are they actually caring for those communities? And that's something that we're still trying to really finalize how we can assess that. And this is our last slide. Just wanted to share with you about a couple of our students who were from rural areas so that you can read their story and their background. They're both such wonderful young people. Gustavo Gasca is the dentist in the lower part of the slide, was a first-generation high school graduate. He was the child of migrant workers who came to this country and did really well in high school, college, came to dental school, and is now back practicing in the same community that helped to raise him. So community education really makes a difference, and be glad to answer any questions. I know Azra would as well. So I'd like to hear from you all now.
Thank you both for your presentations. Dr. Wilson, I was just wondering more about the model that you have with your students working in schools in your communities. What was that process like? And is that something that was state funded or supported, or is that an initiative your school took on?
Are you referring to the school-based program with the elementary schools?
Yeah.
Dr. Wright, do you want to say something about it?
So you want to know about the model that we have?
About the model and just the process, was it initiated by your school, or was it something that the state initiated and we're a partner on?
Actually, the county reached out to us and said, the county that we have the school-based program, there's only one dentist in the county, and that dentist does not see children. And so the school district reached out to ECU, our dental school, and asked, what can we do? Is there anything we can do? And so we applied for a grant through the Duke Endowment, and they funded us to do a school-based oral health program. And with the funds that we received, we hired hygienists. Our dentists go out there, do exams. The hygienists go out and do prevention. And our dental students also go out and do oral health education. And so they funded us for 3 years. And at the end of 3 years, we want to be self-sustaining. We bill Medicaid for the services we provide. And so the billings from Medicaid is going to make the program self-sustaining. And then we just received funding to do a second program in another similar county.
Other questions? Yes, sir.
Curious to know if you said you were partnering with community health centers in your area?
We do in some areas. For example, probably the gold standard is the one our site in Ahoskie, North Carolina. Are you from North Carolina? But you know the state, right? Yes, and it's the only Ahoskie in the entire United States. Fun fact, okay? The Ahoskie Community Service Learning Center is actually co-located like right beside a federally qualified health center, the Roanoke Chowan Community Health Center, and and our school is the dentist. Our clinic is the dentist for all those folks. And so, as you know, they receive some funding to provide for oral health care for their patients. And so they work with our Community Service Learning Center, but they also have gone beyond that and they've raised some additional funds to provide care because it's never enough, right? There are never enough resources. At all of the sites, we have relationships. We have community advisory boards. So we have people from education, faith-based, healthcare, health department, et cetera, education system, town council-y kind of people and patients, of course, but we're not all as directly partnered with the federally qualified health centers. We are with some of them, but not all of them, and it really makes a difference. Yes, ma'am. Yes, the question was about K through 12. Did you mean 12 years old or 12? K through 12. Okay. Yeah. One of the big challenges with, and Azra, you probably could comment on this as well. When you're doing recruitment, it's a long process, right? And being involved at, say, the elementary school level is kind of, it is kind of tough. But we do go to that level. The National Dental Association, which is the traditionally African American dental association, has a program called Lessons in a Lunchbox, which is a lunchbox that has a carrot for a toothbrush and it has some other little cute things in it, and you can get them from the NDA. And our students have used that going into some of the schools in areas. One in particular that I'm thinking of now, the student actually went back. She's a Lumbee Indian, and she went back to the elementary school where she had gone to school. Same principal was still there, and did the outreach there. We're doing more with the high school students. The challenge that I think we all have is resources and having the folks who can actually do that. Wanda, did you want to say any more about outreach to the younger kids?
We do things throughout the year, like give kids a smile. I mean, there's something going on every month where we're out in the schools actually doing oral health education to the children. And sometimes, and it may not, may not be there for career type things, but just seeing the dental students there, giving them oral health education and, gives them an idea sometimes that, or at least they can see people, students who are in school, in dental school, and it's something that they may aspire to do.
And again, people who look like them is a really important part of it, because many of our students, it wasn't until they were in high school, for example, that they saw an African American dentist or physician or something like that. And so it's really important, and and we don't want to overly burden our students who are from the underrepresented groups, but many of them really understand how important it is for them to go into the communities and be that face of our profession.
This question is to both presenters, but it's also about all of the presentations today. I'm at an institution that doesn't have in their mission taking care of the state population. It's a private institution. It's in a state that has, I don't know how many schools, maybe one's opening next week. So we have 7 or 8 or 9 med schools in our state. And so we're not responsible for the state. How do we, and yet I have 3 HRSA grants that say I'm working on rural and underserved populations. And all of the presentations today have talked about going back to the mission, and it's not in our institutional mission. So what are your recommendations for an institution that doesn't have rural health as a mission for addressing the upcoming cliff or collapse of our rural healthcare system?
Azra, do you want to start with that? Okay. Okay. I think that it's really important that, and our mission is very almost like unapologetically about North Carolina, and we're a state institution, right? But I also think that we want to educate our healthcare professionals, this next generation, to be very, very conscious global citizens, if you will. And so I think identifying the communities, however you identify the communities of need that that exist, and I think that looking at opportunities to reach out to rural areas is still important, even if they're not going to necessarily. And Azra, I'm sure that y'all's students go to a number of community-based programs or federally qualified community health centers that are not in the state of Arizona. Is that right?
Correct. So we have about 67 community health centers across the nation that our students go and rotate through. When I think it's really important when we're also bringing in students that they understand that coming to our program, they are going to go to those community health centers. They are going to go to clinics that they may not necessarily want to go to. But getting them out of those comfort zones is extremely important, because once they go there, they come back and say, thank you for sending us there. I didn't realize that there was such a need out there. So it really does open their eyes to wanting to go and serve in those areas. And we start off again, like a lot of dental schools, with our students also going out into elementary schools as well, and also educating them about the importance of oral health, and doing things from sealants to even as far as going and educating the parents as well on the importance of oral health.
So how long are your students out at these community programs?
So they go anywhere on between 4 and 5 rotations, and they're gone for about 4 to 6 weeks on those rotations.
How do you deal with the pushback? And I'm going to say something political with this, but I'm in a blue city, and our learners absolutely refuse to go to red counties in Pennsylvania. They say they will be discriminated against, they will be oppressed, they will be terrorized if they go to that. And their social advocacy positions prevent them from seeing those red counties as people.
Yeah, that's a tough question and a good question. I mean, I don't run our integrated community service partnership program, so I really can't talk too much on it. But from what I do understand, what I hear from our faculty is that we really do listen to our students. We try to get to the underlying reason as to why they may not want to go somewhere, and then recommend certain places that would be a better fit for them. Ultimately, at the end, we say, we tell them, think about it, and you may end up liking where you're going. So, at the end of the day, really leave it up to the student.
That is a tough one. Even in North Carolina, there might be some communities that might not be as perceived as diversity friendly. Do you think that would be a fair thing to say, Dr. Wright? Yes. I mean, one of our students a few years ago said that someone in the grocery store behind her was like touching her hair. It was pretty creepy. And and she had beautiful hair, by the way. I've never touched it, but it's very beautiful. But seriously. I mean, we tell our students that everybody has to go to one of our sites, and so, but we have to be really clear about if there are situations that come up in the community that we will address those. But I think the other thing, and this came up actually within the context of our professional ethics curriculum that I have the chance to coordinate. And it's kind, and it first came up with regard to dealing with the difficult patient. And our teaching partner from the medical school, who's wonderful, Ken DeVille, a student was talking about how this patient's just like really mean and they're disrespectful and I shouldn't have to treat them. And there was an opportunity for some learning there that it's not a 50-50 thing like it is in regular society. Like if they need to be nice to me if they want me to help them, that as healthcare professionals, we have a greater obligation. We have to go further. And so therefore, everyone deserves the right to healthcare, even people with whom you may disagree. And we certainly don't want our students to be in a situation where a patient will say, well, I don't want you to take care of me because your skin is a different color than mine. But at the same time, they have to understand that we have an obligation to take care of all members of our community, however we define that community. Wanda, do you want to say any more about the work that you do within your community oral health practice course regarding cultural competency and
Only that our students receive, they receive a lot of didactic coursework in public health, cultural competency, health literacy. We believe in our school that public health is like one of the core courses, and we devote almost 200 hours of public health in our curriculum over the first 3 years before our students go out in to the community service learning centers. So our students get a lot of, like I said, the cultural competency and implicit bias training. So hopefully when they go out, and there are, you saw the wide range across the state, and some areas of the state are not very friendly to some of our students. But our students still go out there. Some of them come back and said it was a great experience. Others say it was challenging.
Yes, that can be. And so we have a responsibility. One time we had a situation, and it was not in the western part of the state, I will say, where there's housing that's provided by our area health education centers. And there was a situation where only 2 of the 4 students were going to be staying in the housing. And one happened to be a student who was African-American male. He was a pretty big guy, had played football for North Carolina A&T before coming to dental school. And the other was his classmate who was going to be there was this rather petite, blonde-haired young lady. And she was engaged to a guy within her class, and her fiance was fine with her staying in this, just the 2 of them being in the housing. But he was very concerned about that from the standpoint of the community. And so our public safety, our Sergeant Hill in Greenville called and talked with the police department in this community. And they said that they didn't think that there would be a problem, but they would be very mindful of that. And so, it all worked out, but we kind of had to have the conversations ahead of time, and we had to make those provisions.
Also, another thing is that when our students also go out on those rotations to maybe areas they may not want to go, we do provide an enormous spreadsheet with tons of information from students that have gone to those sites prior. So they get a full list of, information as to where they're going, the type of procedures they'll see, the type of patients that pretty much come through those clinic doors. If the clinic that they're rotating through does provide housing, does provide stipends, anything like that, we just give them so much information that they can make the best decision possible. On top, also on the public health, all of our students also graduate with a certificate in public health. So they already go into those community health centers with an understanding of public health.
and I know this is not my session, but I just wanted to chime in because I think from what I'm hearing from you, it's more of a bigger systemic issue. So I really want to encourage us to think about one of the reasons we're here is to disrupt the system and bring things back to our institution that really need some awareness and change. So I can tell you, as being like number 4 currently in the country in diversity, that does not come without challenges. Like, being innovative comes with a little bit of drama, and it comes with things we gotta face and fix. Like, facing truths are really hard. So with a student body that is 50% URIM, that brought up some stuff that I'm not gonna say we wasn't ready for, but it made us move a little quicker on how we build policy. So I'm not sure if your leadership structure is supportive, but sometimes that means putting support in place for students when they have to go places where they might feel unsafe or scared or just unwilling. But the other part of it is making some systemic policies on when we would no longer work with a site, when we would place policies in place for our students and residents when they are mistreated by patients. And let's say a patient doesn't want to see a student because of X, Y, Z, and we provide the patients very respectfully what their options are, who's available to be seen for X, Y, Z especially, or whatever. However we set up policies, those have to now force accountability. So my thing is, it sounds like it's a student support piece, it's a professional growth piece, because our job is to take care of everyone as medical professionals and as healthcare professionals. But then the other piece of that is how we're changing from a policy-driven perspective, like as a whole, like healthcare system, right? So if we're changing medicine and how it looks, like we're going to face things we haven't had to face before, because now our workforce looks different. So I think that's part of this program today, is that we really start to think about those things as a collective, so we can like come up with strategies and brainstorm together, and then we gotta go try them. They don't always work. So we've been doing all this research on like inequitable grading and like all of these different things, because that's what's happening now as we have a more diverse class. That one voice is no longer one voice, it's many voices, because our class is very diverse. So I think that's the direction we're trying to move the community through as far as like healthcare. So rant over. And we're going back now. So we'll end on that note, drops mic. We will head back to close us out. Thank you.